images that have been prepared by Diane. But today, she is going to be with us and she is going to share some of the specimens that she has in her archive, and she is going to show you the features of what we, as morphologists, recognize as hypoplastic left heart syndrome. But the situation has become a little bit contentious. So I'd like to start off with an introduction to the problems. And for those problems, we can go back to the origin of the term itself. And as far as we can work out, the first time that anybody spoke about hypoplasia of the left heart in terms of a syndrome, it was Noonan and Nadas. Jackie Noonan, Alexander Nadas, can be considered the father of American pediatric cardiology. Jackie was chairman of pediatric cardiologists at the University of Kentucky in Lexington for very many years. But it was way back in 1958 when they produced this seminal discussion of the entity we're going to be looking at today. And as you see, according to their paper, it was Lev, Maurice Lev, a great pathologist, who coined the term to describe a group of anomalies. And this is important because what Lev was grouping together was hearts that he saw as a pathologist. And he took as his common denominator an obstructive lesion, atresia or stenosis, on the left side of the heart. And that begs the question as to what is a syndrome. Because what we're going to show you today is that hypoplasia of the left heart can be seen in many guises. And the question is, how many of those guises should be grouped together within a syndrome? So what is a syndrome? Well, I went to my fount of knowledge, which is the Shorter Oxford English Dictionary. You see here a concurrence of several symptoms in a disease. Well, symptoms are not a great deal of use to us as morphologists. I've also been discussing this at length with Tom Carl. And Tom Carl, the pediatric cardiac surgeon, again pointed to me the fact that a syndrome is a set of medical signs, symptoms, and I found that confirmed in what now is the fount of knowledge, Wikipedia. So for you as clinicians, when we're talking about a syndrome, we are thinking of signs and symptoms. But then, although Noonan and Nadas maintained it was Lev who coined the term hypoplastic left heart syndrome, that is not in fact true. Because what Lev was talking about as a pathologist and a morphologist was hypoplasia of the aortic outflow tract complex. And what is significant for our discussions today is that around this time, Lev produced two descriptions of his findings. This is the first one, to which Noonan and Nadas had referred, 1952. And what is interesting is that in that initial description, Lev included cases with ventricular septal defect. But then subsequent to the account given by Noonan and Nadas, he produced a second description of these hearts, and this time he excluded the cases that had deficient ventricular septation. So this is the conundrum. Should we or should we not be including cases that have a ventricular septal defect within our definition of hypoplastic left heart syndrome? So let's go back to the Noonan and Nadas study. And here you see they analyzed 101 cases of which they had morphologic confirmation of their clinical features. It's interesting to look what they included in this 101 cases. 15 had atresia of the aortic valve, 3 having combined mitral and aortic atresia, 12 aortic atresia with mitral stenosis. They had 5 that had mitral atresia. And this is key to today's discussion. They had 4 with mitral stenosis, but then look what else they were including. They had 6 where the primary lesion was atresia of the transverse aortic arch, but the greater majority of their cases had hypoplasia of the transverse aortic arch. Now remember, they were grouping their cases on the basis of the clinical findings, signs and symptoms. What is key that when they grouped their hearts together and they coined the term hypoplastic left heart syndrome, some patients in each group had a ventricular septal defect. Indeed, 1 or 2 of them had atrioventricular septal defects, 1 had congenitally corrected transposition, but the greater majority presented with what now we would call severe coarctation. And I'm not sure any longer we would be grouping those as having hypoplastic left heart syndrome. But what we can gain from the study that they made way back in 1958 is the grouping of these hearts. And if we look at them in that fashion, we can see that some had mitral and aortic atresia, some had mitral atresia and aortic stenosis, some had mitral stenosis and aortic atresia, and then others had mitral and aortic stenosis. And DIANE is going to be showing you examples of all of these. But what we should then remember is that some of these groups are found only with an intact ventricular septum, but the combination of mitral atresia and aortic stenosis is found only with a ventricular septal defect. I'm going to come back to that. And to me, if we are to determine the pathogenesis, we must now not compare apples and oranges. And that is why what we are going to be emphasizing today is the importance of the specific phenotype. And that is because the left ventricle can be hypoplastic in multiple settings. DIANE is going to show you a very nice example of double outlet right ventricle with mitral atresia. And in this setting, the heart you're going to see, the left ventricle is grossly hypoplastic. The left ventricle can be hypoplastic when there's double inlet right ventricle or atrioventricular septal defect. On occasion, when there's an isolated ventricular septal defect. The left ventricle can be hypoplastic when it supports the pulmonary trunk. But at the moment, we exclude all of these cases from the definition provided by the International Nomenclature Committee. And this is that definition that too goes a long way back now, as you see, 2006. But this definition has now been carried forward for the descriptions that will appear in the 11th iteration of the International Classification of Disease. If you go back to that paper, 2007, you'll see this bewildering table that was prepared by the surgeons. It's a little difficult to see. I'm going to concentrate on just one point, because you see they argue in this table that you can have a ventricular septal defect that can be restrictive or non-restrictive in various settings. And we don't see this as morphologists. But you note, in the combination of aortic stenosis, mitral atresia, they only have cases with a ventricular septal defect, and that is what we do see. And this will be the case that Grace is going to present to you. But to me as a morphologist, and DIANE as a morphologist, what we are going to see is the pathologic phenotypes, the combinations that Lev described in the first instance, mitral and aortic atresia, mitral stenosis and aortic atresia, and that mitral and aortic stenosis and mitral and aortic stenosis with the valves commensurate in size to the ventricle. And we see all of these in the setting of an intact ventricular septum. And DIANE, along with Adrian Crucian and with Elizabeth Stevens, who's now been working at the Mayo Clinic, we've been looking at these hearts in some detail. With Adrian and Bill Chowdhury, we published a paper 3 or 4 years ago now, where we reevaluated the syndrome from a developmental and morphologic perspective. And that is the key to our groupings. And then with Elizabeth Stevens and with Diane, we looked at the hearts from Chicago and from Florida. And we've recently published this review, again, concentrating on the integrity of the ventricular septum. So what we need to be distinguishing is what we are to put in the syndrome, as opposed to those hearts that are perhaps better described as having left ventricular hypoplasia. And I'd emphasize again, the left ventricle could be hypoplastic in multiple settings. So the question we're going to put to you in the remainder of this afternoon, should we consider all these variants as being part of the syndrome, or can we make a case for including the integrity of the ventricular septum as part of our definition? And I believe if we can, but we must also recognize that we can find gross hypoplasia of the left ventricle when there is a ventricular septal defect. We're going to illustrate that to you in Grace's presentation. Diane is also going to show you one example of gross hypoplasia, but what she's going to concentrate upon is the classical variants that we as morphologists think should now be defined as hypoplastic left heart syndrome, including in our definition the integrity of the ventricular septum.
Looking at this particular specimen, the pulmonary artery is much larger than the ascending aorta, as we can see from the anterior aspect, and there's a very large arterial duct. This is classic when you have aortic atresia and mitral atresia. The aortic isthmus also shows a ridge in the juxtaductal position, so there's also a coarctation. To me, this tells me that the aorta was atretic for quite a long time, because the ascending aorta is basically now serving as a conduit for the coronary arteries with retrograde blood flow. Looking at the outside of the heart, the coronary arteries will typically outline the small left ventricular cavity. This particular specimen has a very large right ventricle.
Shall we start
with
again?
very coarse
Okay.
right ventricular trabeculation.
Well, good afternoon to you all, ladies and gentlemen.
There is
You can see by the title, it's up on the screen at the moment.
atrioventricular connection.
We're going to be discussing
This is the
hypoplastic
left
heart
atrial
syndrome.
appendage. It's tubular
To be
nature that's
precise,
crenellated along its edge
going
and
to
a
be
narrow
discussing
attachment to the vestibule. Here's the coronary sinus in the left atrioventricular groove, and at the base of the atrium, a small dimple can be appreciated, which is marked.
Guys, we're going to stop this in a minute, okay?
There's the back edge of the oval fossa, which is probe patent. There's a muscular border at the atrioventricular junction and no communication between the left atrium and the left ventricle. In this particular setting, with mitral atresia, aortic atresia, the left ventricle takes on a very narrow slit-like appearance, and there is no endocardial fibroelastosis. The lining is virtually smooth and has the appearance of normal endocardium. And to make the last point here, the ventricular septum is intact. So this is a case representing aortic atresia and mitral atresia. The next specimen was an explant, and by that I mean this patient has a new heart. This heart was transplanted, so we don't get much of the atrial and arterial trunk component. But here you can see the tiny aortic root with the coronaries coming from that aortic root, and this string is in the pulmonary valve. You can appreciate how much larger that is. This particular specimen was cut in a 4-chamber plane, and the pectinate muscles from a little bit of the right atrium remain. This is the right ventricle, and here is the left ventricle. The interventricular septum and the wall of the left ventricle are globular and very hypertrophied. The mitral valve is extremely stenotic with virtual fusion of most of the tendinous cords and very hypoplastic papillary muscles. And within this ventricle, you can see this thick lining of endocardial fibroelastosis secondary to the turbulent blood flow within that small left ventricle. Also here at the apex, there are all these tiny little sinusoids, if you will, where the endocardial fibroelastosis pretty much cordoned off the apex of that left ventricle. And if we look at the anterior wall of the same heart, on the epicardial surface, you can see all of these tortuous coronary arteries, and this is a clue that there's possible coronary to left ventricular fistulas. This one isn't shown all the way out, but I have a much better example for viewing in the next particular specimen. This particular specimen, again, was an explanted heart, and I have shaved off the posterior wall of the left ventricle. Here's the tiny aorta with the coronaries left and right arising from it, and the pulmonary trunk. On the epicardial surface, there is large ectatic coronary arteries, and actually the left main coronary has become atretic secondary to no antegrade flow. And this is typically associated with some very large coronary arteries on the epicardial surface. This one involves the right as well. And when I take this wedge away, you can see the quite large track between that ectatic epicardial coronary artery and the left ventricle. So a very large coronary to left ventricular fistula. And this is not seen in particular specimens that have a ventricular septal defect. So this specimen with mitral atresia, or excuse me, mitral stenosis and aortic atresia has an intact ventricular septum and fits one of those typical phenotypes in hypoplastic left heart syndrome. This particular specimen shows us the free wall of the right atrium and ventricle removed, and it represents a heart that has a double outlet from the right ventricle. This is the oval fossa, the eustachian valve, and the coronary sinus, and you can see the tricuspid valve guarding the inlet. The outlet septum here is quite thick, and you can see that there's a complete subpulmonary muscular infundibulum and a muscular infundibulum at the base of the aorta. The tricuspid valve is quite thickened and rolled in this area for one reason, most likely because there is a ventricular septal defect. This is a tiny restrictive perimembranous ventricular septal defect. And when we look at the left side of the heart, the epicardial surface shows us very much what we see in those hearts with the classic hypoplastic left heart syndrome, where the coronary arteries will outline the tiny left ventricle. The left atrial appendage is here, and its narrow attachment within the left atrium. The flap valve of the oval fossa is probe patent, and here is a dimple at the floor of the left atrium where the mitral valve might have been. This has a muscular floor between the left atrioventricular junction, so mitral agenesis, if you will, and the coronary artery, or the circumflex branch of the left coronary system, runs in that left atrioventricular groove. This left ventricle is very similar to what we see in those hearts with mitral atresia, aortic atresia, where the ventricle is very slit-like and it has a very smooth endocardial surface. Most likely this ventricle maintained its small size only because of the small amount of flow through that tiny restrictive ventricular septal defect. The difference between this heart and the previous hearts that we presented and discussed is that there is a double outlet from the right ventricle, absence of the left atrioventricular connection, and a ventricular septal defect. So secondary to these features, especially the double outlet from the right ventricle, we cannot include this in the group of hypoplastic left heart syndrome. Okay.
Let's go.
This particular
Hi guys, I'm very happy for this opportunity to share this very interesting case with you and to be able to participate on this amazing panel of these great experts. So I'm very, very happy for that and thankful to Congenital Heart Academy. I have no disclosures about this talk, and I really want to thank the Heart Center team here at Sidra Medicine in Qatar, especially to Dr. Haitan, to Dr. Gurdeep, and to Dr. Z, who provided me the images for this presentation. So today we're going to talk about a full-term baby who arrived in our hospital when the baby was 4 weeks of age. He was born in another country, was a full-term baby, nothing positive on the antenatal care. The only thing is that he had a sibling with congenital heart disease, but he didn't got a fetal echo, so he didn't have fetal diagnosis. He was born with no problems. He was sent to be with the mom right after, but with 1 hour of age, they found that he has cyanosis, 85% saturation, so he was started on oxygen and was monitored. After 1 hour, so when he was 2 hours of age, he developed respiratory distress, needed to be intubated, and they started prostaglandin. Echo was performed, and they could see that this patient had hypoplastic left heart syndrome and interruption of the aortic arch. So with 4 weeks of age, this patient was sent to us. When he arrived, he was in a fair clinical status, but he was on high settings of mechanical ventilation, but has no circulatory issues so far. So this was the echo that was performed when he arrived. So here we can see the mitral atresia and the hypoplastic left ventricle. Here with the color Doppler, we can see there's no flow through the mitral valve. We can see there's a VSD and a small ASD. Here another image showing that. So he was sent through the CT scan as well. So the CT scan could show the mitral atresia and the hypoplastic left ventricle, and the VSDs as well. They are marked with the stars. So here we could see on the echo that we have a patent aortic valve and a good anterograde flow from the LV to the aorta. Here on the CT scan, we could see the same thing, that the LVOT was patent. This patient had something that was interesting as well. It seems like his interatrial septum was attached on the free wall of the left ventricle, excluding the flow from the pulmonary veins to the mitral valve. So all the pulmonary veins were connected on this chamber on the top of the left atrium, and has no connection with the lower part of the left atrium. Here you can see these on the echo image. So you can see this membrane, or maybe this septum here, and the pulmonary vein flow arising on the top of it. And this is posterior structure. So here we go from posterior to anterior, and then we can see here. This is the pulmonary venous drainage. So this patient had partial anomalous pulmonary venous return. You can see that there's obstruction here. There was a gradient of 14 seen on echo. And here is the image of the CT scan of this vertical vein with this obstruction. This is the aortic arch showing the interruption, type A. Here another echo image. And here we could see on the cardiac CT scan as well, interrupted aortic arch type A. Another interesting finding that this patient had was lymphangiectasia in his entire lungs. So you can see here this dilated lymphatic system, and we didn't know how this would behave after the corrections of his problems. So this is the summary of the echo findings. So we could see there was 14 of gradient on the pulmonary veins and a normal size aortic valve and aortic arch with a Z-score of minus 0.7 and minus 1.4. And these are the findings of the CT scan, pretty much consistent with what the echo showed. And this patient was sent emergently to the cath lab. So there they could find that he had 36 of pressure on his left atrium and 16 of pressure on the innominative vein. So we could see 20 of gradient on this obstruction and had a small PFO. And it was confirmed the other findings of the mitral atresia, the left ventricle hypoplasia, the VSD, and the patent aortic valve. So here we could see the angio of this obstruction of the pulmonary vein, of the vertical vein. So here the catheter come from the inferior vena cava, and then they go through the superior vena cava to the innominative vein, and then goes down on the vertical vein. So we could see this, this obstruction. So it was decided to solve this obstruction, placing 3 stents, and the result was very good. So they were able to correct this obstruction in an emergency fashion for this patient, and his patient developed very well. The interatrial septum was opened as well. So as the position of the septum was not ideal, they performed perforation with radiofrequency and placed a stent on the interatrial septum. So this patient was sent back to the ICU for stabilization, and a few days later he was sent to hybrid procedure. So here you could see this in this first image, the pulmonary trunk, and then the branches and the big ductus who had continuation to the descending aorta. So a stent was placed on the ductus to start the hybrid procedure to keep this ductus open. And then there was the pulmonary branch bending. So the LPA and the RPA was bent with a very good result. And this patient was sent back to the ICU after a couple of days or maybe a few days. He was extubated with this good X-ray. And then he was kept with us on the CICU to be fed and to grow and to discuss about the next steps for his procedure. So after 6 weeks from this initial palliation, he was sent again to the CT scan. So we could see the interatrial stent widely open. Here we could see the stents on the vertical vein, and here the stent on the ductus. So the CT scan showed good pulmonary arteries as well. And then he was sent to the cath lab for evaluation. So as we can see here, the pressures on the left atrium are really, really low, are really good. So it was 36 before the procedure, now it's only 7. And all the stents are widely open. And the pulmonary arteries have a good pressure, 10 on the LPA and 14 on the RPA. So this patient now is waiting for his next procedure that we are going to perform probably next week. So these are the images on this last angiography study. So we could see the good branches of the pulmonary arteries and the stent that is open to the descending aorta. And something that is very interesting on this case is lymphangiectasias, they resolved. So we couldn't see them anymore. So releasing the high pressure on the pulmonary veins were able to solve this issue. I want to thank all of you. Muito obrigada. And I'm happy to answer any question that you may have about this patient during the discussion. Thank you very much, guys. I'm really happy to participate.
So what you've seen this afternoon, ladies and gentlemen, is that the left ventricle can indeed be hypoplastic in multiple settings. We haven't shown you an atrioventricular septal defect with right ventricular dominance, but you're well aware of that pattern. We haven't shown you an isolated ventricular septal defect with right ventricular dominance. But again, if we saw that, we would not call it hypoplastic left heart syndrome. DIANE has now shown you an exquisite case of double outlet right ventricle with mitral atresia. And she's compared the similarity of the left ventricle in that setting with what we have when we have combined aortic and mitral atresia in the setting of what we call the syndrome. But at the present, we exclude cases with double outlet right ventricle. So we come back to what should be our definition of the syndrome. And should we be including that case which Grace has shown you, in which the features are what we might call mitral atresia with patent aortic root? So I've already emphasized to you in my introduction that at the moment, on the basis of the definitions provided by the International Nomenclature Committee, we exclude the hearts with atrioventricular septal defect, isolated ventricular septal defect, double outlet right ventricle. We also exclude cases that might have transposition. So the real question is whether we should include those hearts that have, as I say, what we might call mitral atresia with patent aortic root. And the key point here is that recently we've seen guidelines offered by the European Association of Cardiothoracic Surgery, along with the Association for European Pediatric Cardiology. And these appeared very recently in the European Journal of Cardiothoracic Surgery. And that is what has prompted for me this current definition of what is syndrome. Because they did include mitral atresia with patent aortic root as part of the syndrome. I would rather suggest to you that it is a well-recognized entity in its own right, but I don't think we should include it as part of the syndrome. I've been interested in this lesion for quite some time, and as you see, with my colleagues from Pittsburgh, we published a paper in 1983 on this topic. Now, DIANE will remember this very well because she just started working in Pittsburgh at that time as a pathologist's assistant. And this is just a year later when we first met each other and started working on the congenitally malformed heart. So there are various entities that we can put together as mitral atresia with patent aortic root. Here is one potential candidate. We have mitral atresia. You see that dimple in the floor of the left atrium. DIANE has shown you that several times now. But this time, the patent aorta is arising from an incomplete right ventricle, and the left ventricle is dominant. So in fact, we would not be calling this mitral atresia with patent aortic root, because arguably the mitral atresia is in fact tricuspid atresia, because this is left ventricular topology. So it is atresia of the left atrioventricular valve with patent aortic root, but it's not what we've been looking at today. But this is another heart from the Pittsburgh archive, which does show you mitral atresia with patent aortic root. There is an imperforate mitral valve. The left ventricle is hypoplastic. In fact, the aortic root is quite well developed, but there is a muscular outlet ventricular septal defect. And this time, the left ventricular morphology is quite different from all the examples that Diane showed you just a few moments ago. And here's another one, again from the Pittsburgh archive. Mitral atresia due to an imperforate valve. The left ventricle is hypoplastic, not quite as hypoplastic as the first one I showed you, but still delimited by the coronary arteries. Quite a large aortic root this time, and a perimembranous central ventricular septal defect. So we get mitral atresia with patent aortic root in various forms. And this is a case that Diane herself shared with me to show you this afternoon. And it's another example of mitral atresia with patent aortic root. There you see the mitral atresia, this time due to absence of the left atrioventricular connection, but this time the left ventricle is particularly hypoplastic. Now Diane has closed up here on the ventricular arterial junction. There you see the hypoplastic left ventricle, the patent aortic root, and the key now is that there is a restrictive perimembranous ventricular septal defect. Here in a beautiful image, she's opened out for you the aortic root, and you see there's a bicuspid aortic valve and a restrictive ventricular septal defect. And there you see it from the right side. She's put this probe through the restrictive central perimembranous ventricular septal defect. And again, there was no fibroelastosis in the left ventricle because it was mitral atresia. The flow coming into it was through the restrictive defect. So I would suggest to you that in fact, mitral atresia with patent aortic root is an entity in its own right. And just as what I would like to call syndrome, those cases that Diane showed you, it comes in various guises. But all the combinations include a ventricular septal defect. And because of that, they will have a totally different morphogenesis than those hearts that Diane demonstrated to you with an intact ventricular septum. And to me, that now is the key. Because we're all trying to work out the morphogenesis of hypoplastic left heart syndrome. And the question that we have to pose, when does the left ventricle stop growing? What makes it stop growing? Is the cause of that cessation of ventricular growth hemodynamic? Some have argued it's because the atrial septum becomes intact. Or are there genetic cues which tell the ventricle that it has to stop growing? What's for sure, if the cause is genetic, the insult may well not start. We know it does not stop growth until after the embryonic interventricular foramen is closed, and that is why the ventricular septum is intact. And that, I do believe, is why we should be grouping these cases together as a syndrome, because they do, in my opinion, represent an acquired disease of fetal life. Diane has showed you those features that are acquired disease, the fibroelastosis. And then in the presence of mitral stenosis, the fistulous communications between the cavity of the left ventricle and the coronary circulation. These are all part and parcel of what is an acquired disease of fetal life, and we do not see those acquired changes in the presence of a ventricular septal defect. And all of this is important for those who are seeking to model hypoplastic left heart syndrome, because as yet, there have been no mouse models created that produce those features that Diane showed you today in the setting of an intact ventricular septum. So it is my belief that we will only clarify the cues that underscore cessation of growth when we make family studies comparing apples with apples. And to my mind, it is key that the integrity of the ventricular septum should now be considered part of the definition. And together with Diane and Adrienne, we've written a review that is about to be published in Nature Reviews Cardiology, where we argue very strongly that the definition of hypoplastic left heart syndrome should include the integrity of the ventricular septum. But this is a matter we can discuss. So now we'll open the discussion and we'll try and answer your questions.
Okay, thank you very much, Dr. Anderson and Dr. Diane. It was amazing talks from both of you, and the specimens were very nice. And we are very happy to have here with us as panelists to discuss these issues with us, Dr. Silverman and Dr. Adrienne Prussian. And thank you very much, guys, for participating today. And I think we're going to have good things to discuss. I just want to open this with the considerations of Dr. Silverman, please.
Well, thank you very much. There's very little to say, in fact, after this talk. This is the second talk that Bob has given on hypoplastic left heart syndrome. And I think it's pretty clear and emphatic that the syndrome includes an intact ventricular septum. So that there is a hypoplastic left heart syndrome, and then there are diseases where the left ventricle is hypoplastic, and that one should make that difference, and that in fact one should use sequential segmental analysis, and when you do that, it makes no difference how you describe the syndrome, but everything is absolutely clear. Grace, I thought your talk was very interesting, and what a beautiful example of a combination of interventional and diagnostic techniques, and so wonderful to see the lymphangiectasia disappearing when you relieve the obstruction. Unfortunately, in some of the patients, when it's too long standing, especially as the hemodynamics change so dramatically after birth, with the removal of the placenta and the establishing of circulation, you would assume that the lymphangiectasia was not that developed in this patient from the hemodynamics. And yet, that's, I think, could be described as an extensive hybrid procedure. And so the interesting thing about the patients is that sometimes doesn't matter what the particular anatomy and pathology are, you have to still direct the hemodynamic attention to the various abnormalities that you showed so beautifully. And Diane, as usual, I think, you know, your specimens are so beautiful. And I'm so grateful that you shared them again with us. I'm also very interested in the one specimen that you showed with the endocardial fibroelastosis and those endocardial, the intramyocardial capillary or arterial vessels within the body of the muscle of the ventricle. Because I think that we've not addressed sufficiently the presence of ventricular coronary connections in hypoplastic left heart syndrome. And I think if you look at this echocardiographically, you can see that by lowering the scale, that many patients with left heart hypoplasia indeed have small little ventricular coronary connections. So that's all I have to say. And I'm sorry, Bob, that your paper is not published so that we can get hold of it. But I think that you've emphasized very clearly for us this morning your indications, and it's entirely supportable. Thanks very much, Bob.
And thank you, Dr. Silverman. I think the paper is published because when I entered on the DOI and it was there. So I think it's published maybe one week.
Correct, Grace. You can get it as a DOI. It's not yet appeared in the journal. I think it's due to appear in the journal in February, but you are correct that it is obtainable through a DOI.
Yeah, I tweeted it and placed on LinkedIn the link so everybody can take a look already.
For the 200 people that are here, can you contract the specimen? What does DOI stand for?
That is how you obtain the preprints of the paper before it appears in the journal, and you can now track it. And in fact, I gave in the slide, if you go back to my presentation, you'll see that in one of my slides, I gave the DOI of the manuscript that's about to appear. Great. So it is, when you back up on the on the webinar, you'll be able to find the DOI.
It's on our social media as well. I don't know what does it stands for, but it's like the identification of every paper where you can find it online, but I don't know.
I think it's digital something identifier, is it not?
Maybe, yeah, maybe something like that.
Sounds good. Sounds good. Anyway, it's very hard, Bob, to keep up with the papers you read. You seem to be able to write them at a rate quicker than I can read them.
This is true. I'm fortunate now that I'm collecting pen pals from all over the place, and they're letting me join them with my with paper writing. So it's keeping me busy. It's keeping me out of mischief.
Sure.
A lot of people answer to us. So for everybody to know, is digital object identifier. So,
there we go.
Digital object.
We have a lot of questions on the Q&A chat box. Guys, please type your questions as well. We are all going to be very happy to answer those questions for you. Adrian, do you want to add anything?
Can I ask something before we, because
yes,
your
sure.
case was fascinating, and I would like to ask you a couple of questions about your case, because could it be that what you called the malposed primary septum was in fact a divided left atrium?
Yeah, it's something
the
that
horizontal shelf, and it was between the pulmonary venous component of the atrium and the vestibular component of the atrium. And I know Adrian has had a case recently that he was telling me about that has an ostium primum defect. And in Adrian's case, it was the other way around. So in Adrian's case, there was a communication with the vestibular component of the atrium and the right side. In your case, to me, I would have called that a divided atrium with the pulmonary venous component in direct continuity with the right atrium. And the other potentially interesting thing to me, because I think that anomalous pulmonary vein, the pulmonary vein itself was still connected to the left atrium, was it not?
Yes.
So the channel that you were describing could better be described as what's known as the levoatrial cardinal vein.
Mm-hmm. Sure, this is true.
But
because it has a dual drainage, so it was still connected to the left atrium, and it was still connected to that
to the vertical vein.
Yeah.
Well, I think that is what we would call a levoatrial cardinal vein.
Interesting. I thought it was merely a lefted shift of the septum primum, which you described in your previous work, and which the late Paul Weinberg.
Indeed, but Grace and I, you're right, but Grace and I were discussing that, and that is what you find in typical hypoplastic left heart syndrome, and I explained to Grace it was a deviation, but in the case that the echo to me suggested it was a total horizontal shelf that was created in the left atrium rather than simple deviation of the primary septum.
And do you think this has is on the what caused the mitral atresia, but this developed first and then there was no flow through the mitral valve?
Absolutely. I think there's every reason that is the case. And it was pure imaging was beautiful, showing absence of the left atrioventricular connection.
Yeah, Dr. Hatton,
in that case, it looked as though that partition was in fact was imperforate.
Well, I must say that this is a very interesting discussion. And what I think we get from these meetings is that we have to go back and examine our own data. And I would love to hear, Grace, that you've gone back and looked at this and seen whether this really is indeed a levi atrial cardinal vein, as Bob has suggested, with a divided left atrium, or simply a leftward shift. I think you presented it in such a way that it seemed more likely that it was a leftward shift, but it would be an interesting point to relook at the data and see really what it is. And when I say the data, I would include also the CT and MRI scans that you have on the patient, because I think you get a different perspective that way. And maybe you can report back to us at a later meeting when we're talking about hypoplastic left heart syndrome. Again, what do you think?
I agree with you, Norman. I think it's fascinating also that Grace's case had interruption of the aortic arch. And again, this is another reason why I think we should be grouping that as an example of mitral atresia with patent aortic root. The aorta as well was of reasonable size. So I think it's well worth writing up your case, Grace, because the combination of features is of particular interest. And I agree with Norman that we ought to go back and look at it again. And the CT scan should give you a precise indication of the location of whether it is a deviated primary septum or whether it's a divided atrium. And actually, in your case was quite interesting with the ostium primum defect. As you said, your case clearly was not hypoplastic left heart syndrome. But that isn't it. Do you want to tell us about your case?
Hello, thank you very much for the Congenital Heart Academy for the invitation. Yes, I picked that up on your case, Grace, and it's interesting because now if you look where the interatrial septum is, you may get an idea of where the true septum was there initially. It looks more and more that it was not a deviated interatrium septum, but probably when the people will do the surgery, the next step, they should look carefully in the atrium and describe it. Our case is it's a clear ostium primum defect with a divided left atrium by a ridge that is really at the edge of the ostium primum. So once we enter the atrium and we looked from underneath of this ostium primum, we are able to see the entire ridge that had only a very small restrictive communication between the pulmonary veins and the rest of the atrium cavity. It's a good case, and we hope to publish it. Now, going back to the discussion of the hypoplast left heart syndrome, obviously is not only semantic here. And I'd like to address this to my clinical colleagues because I was just looking back at the SVR trial. It is very important how we name things and how we group things. Even in 2007 or so, they were very careful to mention hypoplastic left heart syndrome patients versus unbalanced AVSD or other types of small ventricles that still require the Norwood operation, but they were not lumped together, because the way we name things and we group things has important implications in how we analyze patients, how we build databases, how we publish our research. So if we lump together entities that do not belong where they should, then we will publish confusing findings. So my request will be for whoever gets a good imaging, whether it's on the CT or in theater in the OR, we should be very careful how we define things and to describe them, because then it's very easy to go back and rearrange them. For example, if tomorrow we'll find a gene or we'll find an epigenetic cause for the hypoplast, then we should still be able to go back to our descriptions and be able to redefine them according to the current knowledge. The problem is when we lump together double outlet right ventricle, like your case with mitral atresia, or mitral atresia with a patent aortic root, and we will call all of this hypoplastic left heart syndrome. And then we make research, we publish findings, and everybody will be confused. So it's not only semantic, it has very important clinical implications.
Yeah, true. We agree.
I have this wonderful book over here, which is a discussion. Essentially, I'm sure everybody's seen it.
Sasha had it also.
Well, there you go. This is.
I'm okay.
But the issue here is, and Adrian, I think that's a very interesting point that you've made for the participants that are at this meeting. It's not for us.
There is a
Yeah, but I emphasize once again that the advantage of sequential segmental analysis is that when you describe everything in detail, in logical language, you can then do what you suggest with epigenetics, because it's in that category. But when you start lumping things together in a simple way by means of simple glib, what do we call it, jargon, then you get yourself into trouble that you can't get out of in terms of what you've just described. So I think that the complete description, as described in our atlas, I don't know, Bob, where's your copy?
I don't have it to hand. I have it.
It's all in your head, right? But the point is that I think that
we are in the
maybe
same school.
I would support your point in that.
I mean, the point that Adrian has made is also so important, because what Grace has shown now, the imaging of that heart that you showed, the patient that you showed us, was exquisite. And what we can see now with echo, with CT, with MR is amazing. And I think the ability now that we have to do sequential segmental analysis is, I mean, it's improved so much since the turn of the century, and there's no excuse now for not giving a precise definition. And the other point, as you say, is now we can see things as we have today, and we can question how we call them, but then we should be able to get a precise description of what we're looking at.
Yes. I have a question and a consideration. The question is for Bob and Diane. What we probably miss a lot in the diagnosis of the hypoplast, or in this very huge world of hypoplastic left ventricle, is something that we really scare us surgeon on the right side. It means why we call this sinusoid in the right side, and why we call this fistula in the left side, and how is the real underestimation of this point? Because as Adrian say, when we do mitral atresia, aortic atresia, I'm sure 90% or mostly 80% of the patient can have a communication between coronaries and the left ventricle.
Well,
but very few paper about this. Bob or Diane?
Well, I don't think you should call them sinusoids anyway. I think sinusoids is a terrible term, and we should ban it. I think they are fistulous communications between the cavities of the ventricles and the coronary arteries. And you are correct that you see them particularly in pulmonary atresia with intact septum. And they are the basis of the right ventricular dependent systemic circulation. The interesting thing is that you don't see them with quite the degree of frequency in hypoplastic left heart syndrome. And I think that is because of the fibroelastosis. And Diane showed you very beautifully in one of those specimens, she pointed it out, that the fibroelastosis had encapsulated the apical trabecular component and had sort of screwed it all up. And so, again, going back, I mentioned that Jackie Noonan was the chairman of pediatrics in the University of Kentucky in Lexington. There is an outstanding pathologist, worked with Jackie there. He's still there. He's called Willie O'Connor. He's a very good friend of mine. And Willie O'Connor, with Jackie Noonan and Carol Cottrell at the time, they published a paper which in the late 1990s, and they showed that if you do histology on hypoplastic left heart syndrome, they found fistulous communications, microscopic fistulous communication in 90% of the cases. So you don't see them overtly, except in rare cases like the one that Diane showed, and there were overt fistulous communication, but they're always there. And I think, Sasha, you are correct that they don't receive the attention that they should do. But I think that the overt ones, correct me if I'm wrong, Norman, but I think if you have overt fistulous communications, that is a bad prognostic sign, is it not?
Correct. But I think, so Bob, I would emphasize that point. That if you have big fistulous communications, which we can't call ventricular coronary connections anymore, can we?
I think you can call them ventricular coronary connections. I don't think you should call them sinusoids.
Okay, I'm happy with that. But anyway, so what's a fistula but a ventricular coronary connection?
Exactly.
But my point for the audience here, then I sort of always have to think of the other people that are here that perhaps haven't got the same degree of sophistication or young and learning, is that in order to see these fistulous communications regularly, what one has to do is lower the scale of the color, because the velocity of flow in these fistulous communications is not rapid. It can be down in the mean velocity of 20 or 10 centimeters per second. And in order to see that, you have to lower the Nyquist limit to a point just beyond where the image turns into noise. And when you do that, you will find that there are a number of patients, both for left and right-sided fistulous communications, that you can recognize that are not seen by conventional techniques like angiography. And so they are present in hypoplastic left heart syndrome and hypoplastic right heart syndrome as well. And the technique for recognizing them, which goes to Adrian's point, because if you don't show them, you're never going to be able to go back and find that information. So I would make a plea to the audience that when they do examinations on these small ventricles, that they look at the myocardium and lower the Nyquist limit, or the scale as it's called, to the point that they can start to see interventricular myocardial blood flow. And of course, the new techniques with new kinds of ultrasound, which will be present in the next 5 to 10 years, will allow this to be clearly demonstrated. And I've seen pictures from France where they are using a new form of ultrasound where you can see intramyocardial coronary arteries in every patient. And of course, if you look at histology of a fixed myocardium in from a live animal, as we've done with glutarate fixation, the myocardium doesn't look like the classical muscles, but because the vessels are fixed, it looks much more like liver. So these, I mean, we know that the myocardium is richly endowed with a capillary and arteriolar supply and venous drainage, and soon we will be able to see this on a much easier basis. And I think you can see that this is an important area for our future research. That's it.
If we look at some of the questions that are coming through, Grace, I see that Vera is with us from Sao Paulo. And Vera has pointed to this paper by Cotoni and colleagues. I reviewed that paper and I tried to persuade
Bob,
them
you're frozen.
that was also a divided.
Can I have that app that allows me to freeze you like that, Bob?
Sorry, Norm?
Everybody's frozen now.
No, we're still here. But I reviewed this paper by Cotoni and colleagues. And as I say, I tried to persuade them that it was a divided left atrium, but they would have none of it. So I still think that also was divided left atrium. So Grace, perhaps we can discuss also the Cotoni paper when you write up yours. There's also an interesting question here on our question and answer from Carlos Draconis. And he makes the very good point that the patients present the same way together. So in terms of signs and symptoms, there's every justification for saying that they have a syndrome. And the point I'm making, and the point that Norman was making, if we are going to get to the morphogenesis, if we're going to look at these things, that is where we have to separate them out, even though they are seen to you as clinicians as part of a syndrome. So you pays your money, you take your choice. There was one more question that I think I can ask, which was from an anonymous attendee. You only get fibroelastosis when you have a patent mitral valve. Absolutely. So if you have mitral atresia, you do not get the endocardial fibroelastosis. And you saw that very beautifully in the hearts that DIANE was presenting today. But the other questions, Grace, I think that Sasha and yourself will have to answer that. I see Norman has left us. Adrian can probably offer some answers to some of the other questions.
So we had just a few questions about the case that people answer. I just give the quick question there asking what was going to be the next step for this patient. So we are planning to do a Norwood with the correction of the interruption aortic arch now, and then leave the gland and the fontan for later on. So that's the plan for this baby now. And they asked about the stent. It was a formula stent. So we have a question that I already discussed this with Sasha. He has a very interesting technique, how to protect the pulmonary branches when you do a hybrid. Sasha is very experienced on hybrid procedures for hypoplastic, so I think he can comment on that, and Adrian, of course, if he wants to comment as well.
We learned from Mark Galantowicz, and we consider this experience very interesting. We have 70 cases, and generally 70. Hybrid. And we consider this very interesting because we really reduce the ICU stay, and now we are able to extubate on the table. And we don't use pacemaker wire, we don't use chest drain. The last case was a case where we was not able to use stent. So we use the strategy of prostaglandin and bending. I think that it's very interesting, prostaglandin and bending, because in few centers they are not able or they don't like to use stent on the PDA. And for the bending, we use 3 millimeters every time on the left pulmonary artery. And then we move from 3.5, 4 millimeters on the right. We don't use intraoperative inotropes, normothermia, VO2 21%, and we have very, very good results for palliation of this patient. What I think that, Adrian, is in your discussion is the mistake we do for fontan operation. Every time I say that fontan operation was created for tricuspid atresia, but we use this technique for 100 or 200 anatomic subtype. And of course, the results is jeopardized because we saw this patient received fontan, and fontan doesn't work. And then protein losing problem and other things. For the hypoplastic left heart syndrome, I think the most important is the sequential strategy to approach the heart. And as Bob say, that we have to follow how the blood come in the heart and understand which is the channel to receive the right blood. So this is what we miss a lot, because a lot of paper comes in completely confusion, and probably the real number of patients with tricuspid mitral atresia and aortic atresia, if we consider this patient as probably we know, results are very poor, because this is the worst anatomic subtype for each type of surgery. And we know 2 millimeters of aortic ascending aorta is very black on or white results. So I love this approach to have at the same time clinician, historical pioneers of this job, because probably this is the time of the consensus. because we have a CT scan, we have MRI, echo, we have experience, we have. This is what I feel. Thank you.
And if I can add to that, Sasha, it's very good point, because we see people now using the term hypoplastic left heart syndrome variant. And you see that a lot in papers, in descriptions. And we may compromise on that term, but still we should clarify what kind of variant we have in mind, especially in the beginning when you first get these patients, because then we know what happens in the follow-up. People will copy letters from previous visits, and these mistakes will propagate and they will be amplified. So we don't have many chances to get it right. And I would say that these chances are always in a neonatal period and at the first operation. So it's a big responsibility, but I think we should take it, and we should be very, very clear on what we write and describe, because the syndrome, I know we discuss only that is a manifold of signs and symptoms. We should aim for more. Maybe this syndrome also has the same group of causes and the same group of therapeutic options, so we can make comparisons. Otherwise, we will compare double outlet with mitral atresia, where the aorta it's usually larger, as DIANE showed, and then we will say that the same results would be expected in a 1.5 millimeter ascending aorta. DIANE, by the way, the movies were excellent. Thank you.
Thank you, Adrian.
Go on, DIANE.
I do have a comment to go back to the coronary artery discussion, and you mentioned the histology, that they've seen them on histologic sections. When we did the paper with Elizabeth Stevens, where we looked at all the hypoplasms from Chicago and Florida, I also looked at the coronaries. As you know, we published a paper on the coronaries along with that other paper. The outer appearance of the coronaries many times had me suspect that there were fistulous communications, but when I looked for them, they weren't there. So that tells me that in some of those hearts that did have extensive endocardial fibroelastosis, that those connections eventually got closed off or cordoned off by the EFE or the degree of EFE over time. And so even on the outward appearance, I suspected them, but could not find them when I dissected the coronaries. So.
Good point.
Can I just make one quick point about endocardial fibroelastosis on echocardiography? You know, people have written and said that it's not easy to see endocardial fibroelastosis, and ultrasound doesn't provide you with the same degree of resolution that you can see with MRI or CT, for example. And perhaps that's true. But I think, again, thinking of this in terms of the audience that's listening, there's a key to looking at the endocardial fibroelastosis. And what it has to do is lower the scale and sensitivity so that you increase grayscale. And when you increase the grayscale, then the difference in density between fibrous tissue and muscle becomes much easier to see. So if you're using what they call a bistable with a low grayscale, you won't be able to find this. You have to really use maximal grayscale in order to define these conditions. That's all.
There's another interesting question come in, Grace, which is pertinent to what Adrian is about to do, because we have a question from Miguel Arizapana, who says, in pathological anatomy, is there variation in the distribution of the cardiomyocytes in the right ventricle in hypoplastic left heart? Adrian is about to embark on this precise topic. Adrian, we're going to be taking the hearts from your archive, are we not? We're going to be looking at the myocardial architecture, and that is one of the things we anticipate to solve.
Absolutely, and we got all the approvals now in place. We are working with Robert Stevenson, and you worked with him in the past, to look at these hearts in greater details that is still not possible in the clinical world, because we are going to use imaging tools that are going to offer us histology level imaging on these hearts, where we hope to address questions of architectures, questions of conduction axis, and questions of coronary distribution.
And we also ought to get more information about the fistulous communications, because by going down, as you say, to the level of resolution we get, we should be able to pick up these microscopic connections.
Yeah.
We have one very interesting question. Amna is asking if Schoen complex can be considered as a variant of hypoplastic left heart syndrome.
Absolutely not.
Bob, could you be a little bit more definite about that?
There's an interesting paper, I don't know whether it's been published on yet, from the Melbourne group, in fact, who are arguing that we should discard the Schoen syndrome, that it's a bag, it's a sort of ragtag group of things that are put together. And it's, I mean, shown in the original work, they had the 4 entities. And in none of their cases were all 4 together at the same time. So that is a perfect example where we would do much better just by describing what the lesions are, but it is not hypoplastic left heart syndrome.
Okay, so we are, everybody agrees on that, it's not. So Omar has one question. Is there any role of the LGE MRI to identify patients with endomyocardial fibrosis, fibrinostosis in these patients, and does presence of endomyocardial fibrinostosis change the management of these patients?
Well, that's a good question. I mean, we all know that Pedro Del Nido in Boston has been trying to rehabilitate these patients by carving away the fibroelastosis, and not with great success, I don't think. Adrian, you visited Boston recently, did you not?
Yeah, I think they are still persisting, and it's a matter of refining the selection process for these patients, because we are actually talking about borderline left ventricle. I think it's a different entity, and we may discuss about that. It's not a true hypoplastic left heart syndrome. And in those cases, the endocardial fibrinostosis goes far deeper than we can see on gross examination of the heart. And this is not only on the endocardial surface, but it goes into the papillary muscles in all the subvalvular apparatus. And it may require readdressing at further surgeries, because it either comes back or is not completely removed at the first operation. I would be a bit cautious to mix things together from that point of view. But I would be interested to know whether the new fetal MRI can pick up EFE in utero, because again, we consider this to be an acquired fetal disease, and we don't know what happens before the time when we can diagnose with the fetal scan. As soon as you'll be able to image earlier than 18, 19 weeks, we will find out more. But what do you think, Norman? Probably you may know.
I think that it's a great potential. I don't know of any papers. Again, I haven't read the DOIs, but perhaps there are papers that have that. I try and wait until it comes through PubMed before I read it. But I think, and I think that's a great point, because I think this is an acquired disease, and we see it early in fetuses as well, with ultrasound. No, I just lost the point that I wanted to talk. Yes, well, I'll leave that a discussion for another time.
Have you had any experience with trying to carve out the fibroelastosis? Have you ever tried?
Oh, that's the question, yes. So I just want to put in a commercial here for my colleagues at Stanford, because I think this is a very important issue. The fibroelastosis is thick, non-compliant tissue, okay? And it really affects ventricular filling as much as it affects ventricular emptying. For us soccer fans over here, it's like taking a football and putting the leather inside the rubber bladder. Okay, you can't do anything with filling or emptying the bore. And what happens to the heart that is fibroelastotic is that it has an inability to contract because of this rigid material, and it has an inability to expand because of diastolic filling abnormalities. And we've successfully removed a number of these. Now, the ventricular, when you remove this, it's very easy to remove, from what I gather from Reddy and Hanley on this topic, because you get into a plane and you can really take it out. And in fact, you get a little cap of fibrous tissue you can put on your finger. The ventricle is still small, but it's bigger. So the volume that it starts off with is bigger, and it has the opportunity to fill and empty. And we've had a number of patients that have had this procedure that have been substantially benefited by it. I don't think it should be discarded. I think it's something that should seriously be considered. And I mean, even though the ejection fraction of the ventricle hasn't gone up substantially, the end diastolic volume has gone up. And so that when the end diastolic volume goes up by the thickness of the EFE that is removed, okay, you're working with a much bigger volume in diastole. And if it contracts just the same amount, you have a much better stroke volume. So it really has helped the patients quite substantially. And the dissection has been absolutely beautiful. You can see when it's removed in the plane that you've got no evidence of myocardium, viable myocardium on the outside of this fibrous cap. Your point, Adrian, about the papillary muscles, of course, is very important, because that's really the first hit in endocardial fibroelastosis in any patient, regardless of the etiology. And, you have to do the best you can. Obviously, you can't take the fibrous tissue off the papillary muscle and get left with nothing. So you have to maintain support. So the ventricles are never normal, but I think that they work a lot better. And certainly we've been able to temporize a number of patients, particularly with the presence of pulmonary hypertension on the basis of that non-compliant ventricle, much better. So I would encourage that as a thought process.
Yes. What we learn from the experience of Boston, I think that apart from Hypoplastic, is that they work a lot on the filling of the left ventricle. So they never remove completely the atrial septum. They leave part of the atrial septum. Also, of course, when there is a risk of pulmonary hemorrhage. And they manage the atrial septum very well during the time to try to precharge the left ventricle. But this is something that probably is far from pure fibroelastosis. Because I don't know perfectly, but if we saw the heart from DIANE, no one can convince me that we will be able to manage this fibroelastosis. So I'm sure, again, there is several degrees of fibroelastosis. There is one that, as Norman say, when the left ventricle is already formed, is a good shape, we can try to shave it and work on the left ventricle with the precharge. But I'm sure at the same time that the heart from DIANE, the one with fibroelastosis, we will be never possible to do something of this left ventricle. But this is my
I think that's certainly the case. I mean, that left ventricle was unsalvageable. But there are left ventricles, as we've seen in the spectrum of this syndrome. You notice I didn't mention the name of it, that are not that small. And it is those particular ventricles that may have endocardial fibroelastosis that are salvageable. And I've seen the surgeons start attacking it through the aortic valve, and then coming back from the atrium and attacking it the other way. And again, these are hearts that have maybe got critical aortic stenosis, some of them, as well as the complexes, and the left ventricles can grow in patients with hypoplastic left heart syndrome. And I think this is an alternative and reasonable surgical maneuver.
In fact, we lost one of Diane's hearts in the presentation because she showed a case that is very similar to the combination that you just described. But we're going to, in February, as Grace has said, we're planning our next series, and we want to incorporate the presentations of the specimens from Diane. So we will, one of the sessions we're planning to begin with in February is going to be on critical aortic stenosis. So we will show that case, Norman, and you'll be able to comment again, because Diane, your case, as I recall, has a unicuspid unicommercial aortic valve and limited fibroelastosis, does it not?
Yeah, it does. It has a fair amount of fibroelastosis, but it does have a unicuspid unicommercial valve.
So it will be very interesting for us to show that again, and we can discuss the point you've made when, and Alan McGee is going to be joining us for that presentation. So that will be our second presentation in February. So something to look forward to, Norman, and we can revisit fibroelastosis in that setting.
Guys, It was really an amazing meeting, really. I really like this format. Thanks for joining us, Diane and Adrian. It was very nice. We're just adding a lot of knowledge to all of us who are watching, and this is going to be a good legacy because it's going to be on YouTube, and people can review and share with their teams. So thank you very much, guys, and we are very happy for this series, and see you on Thursday. No, sorry, on Wednesday, and then on Friday again. What is this session?
I wonder whether you can see this specimen, but I have a specimen from my own collection here. Can you see it?
Yes.
Yes.
Well,
Very
this is a fairly big ventricle, and you can see the endocardial fibroelastosis throughout this myocardium here, including on the papillary muscles, and also the interesting issue that it's heaped up underneath the left ventricular outflow tract. And so it's caused in and of itself obstruction. But this is the kind of ventricle, a big ventricle, when you remove the endocardial fibroelastosis on these ventricles, that you have a reasonable volume. And if you've got enough muscle left over here, you have a reasonable degree of function, and they can do relatively well.
But isn't this one, Norm, isn't this dilated cardiomyopathy also? It looks...
No, sir. No, this is from a critical aortic stenosis.
Really?
That underwent a balloon valvuloplasty.
Didn't do very well.
Pardon?
Didn't do very well.
Yes, like a lot of your patients, Bob.
Indeed, indeed.
That's why I match your pathology with my echocardiograms.
I have a couple of hearts, Norman, that look very much like this. And one fetus was even delivered urgently at 31 weeks because they were watching the aortic valve. And once it became atretic, they immediately delivered that baby. But I have it in my collection. So the outcome
I probably have it in my collection too, Di.
Now, it would be probably good to add that for the people participating, since we are concentrating on these maneuvers to rescue left ventricles or to deal with EFE, that we are looking at this problem from the other end. So people should understand that it's not only about hypoplastic left heart syndrome. It's a subset of these patients that could benefit from this. And there are other types of morphologies that could benefit from these maneuvers of rehabilitation of the ventricle.
So there you are. There's your picture, Di.
That's not the case I'm talking about, because this was an
I know,
X-ray.
but I mean, it's one that I have. It's just pick it up. But you can see here that if you could get into this line as a surgeon, you can really get rid of a lot of the EFE. Then, and that relieves all of the diastolic dysfunction in this ventricle.
Wow.
But I think you see that the volume of this ventricle is, if it contracts, is likely to be able to receive a substantial amount of volume and get a better stroke volume and cardiac output.
Norman, but you know that we are going back to the question of what's better, a good Fontan or a bad biventricular repair in the long term. We still don't have an answer to that question.
I think that they're both bad. Unfortunately, yeah. Look, I mean, we can argue about this and show cases forever, but I think we've probably done enough on this patient. Certainly I have. I don't have any more to say.
It was amazing, guys. Ciao, Elio. I haven't seen you there. Ciao, Elio. So, guys, thank you very much. So, see you on Wednesday for the heart failure meeting, and then on Friday again with Dr. Anderson.